A very good afternoon to all of you. I am Dr. K.L. Vairi of Rakcoms College of Medical Sciences. We have with us Dr. S. Rao, President of Medical and Health Sciences University. I welcome you all to this Rakcoms webinar series. Today is the first one. We have 3 more in the pipeline. First of all, I request Dr. S. Rao to give a speech. Dr. Rao represents the president of the university. Earlier, he was working at College, Nepal, under Mahe. He was professor of pharmacology. He became the associate dean of the college. Then he served as registrar of Manipal University for a full 6 years. He was awarded FRCP Glasgow by the Royal College of Physicians and Surgeons of Glasgow during the year 2015. He served as Vice Chancellor of the university, that is Crack Medical and Health Science University, from 2005 to September 2017, and from September 2017 to date is working as President of RKMHS. Now I invite Dr. S. Rao to welcome the audience.
Good afternoon, each and every one of you. Am I audible? Am I audible?
Yes, yes.
So once again, good afternoon to each and every one of you. Not only our RACMHSU family, faculties, staff and students, but also the other delegates who have registered for today's webinar from all over the globe. So we are very happy and proud to present this webinar series. This will be the first one, and we will have 3 more in the series, all focusing on the COVID. Before I talk about the COVID and about the webinar, let me congratulate Dr. Vairi and his team for having organized this webinar, very important webinar. And then, as a health science university, it's our duty, we thought, to enlighten the public and also the professionals. Because as you know, COVID is the one virus which has created so much of confusion and so much of uncertainties, so much of unpredictability. I think first time in our life, all of us are experiencing such an uncertainty. And added to that, the so-called experts, then the media, everybody has contributed and everybody is contributing for the confusion. Each one of them coming out with their own opinion, their own assumptions, their own conclusion. Unfortunately, which has not helped the patients, which has not helped the health professionals also. So our main aim will be to reduce the confusion, to help not only the public, patients, but also the professionals. How we can minimize the confusion and how we can be certain about some of the things which are clear and how can we prevent. So that will be the focus of our webinar series. All our colleagues will be enlightening you on those, and Dr. Vairi will be introducing. Before I hand over to them, let me just take 2 or 3 minutes to introduce about our university. As all of you know, RAC Medical and Health Sciences University was established in the year 2006, and in fact I have been fortunate to start this from the scratch under the leadership of our Highness of Ras Al Khaimah, Sheikh Saud bin Sakar Al Qasimi, who is the ruler of Ras Al Khaimah and also the Supreme Council member. Again, for the benefit of delegates who are outside UAE, you may be knowing UAE means United Arab Emirates, comprising of 7 Emirates. You must be knowing about Dubai, Abu Dhabi, Sharjah. But Ras Al Khaimah is also one of the 7 emirates. We are in the northernmost. Ras Al Khaimah means tip of the tent. So we are in Ras Al Khaimah, and now Ras Al Khaimah is known for its very rapid progress for the last 13 years in terms of tourism, in terms of industry, and in terms of education. So I've been fortunate to start the university from the scratch, and now we are 14-year-old. Now we have actually, our Rakcoms is like a mini world, having 1,300 students from 50 different nationalities. Same way, we have faculty from 30 nationalities, around 300 faculty. And we use the federal hospitals for our clinical services. And we have medical, dental, pharmacy, and nursing programs, the undergraduate programs. And we also have masters in nursing and pharmacy. We are known for our academic strength. Of course, research also we are trying to concentrate. And we have a very good reputation, not just in UAE, but the entire Middle East and Asian and African countries. So today I'm very happy that our team is organizing this, and once again a hearty welcome to you. And let me conclude my speech by ending. See, even though there are so many confusion, you have to just remember men, not to touch men. What are those? Mouth, eye and nose. So don't touch men. And follow women. What it stands for. And out of the women, W-M-E-N, W is for washing hands, O is for observing social distancing, and M is for mask, and E is for exercise, and N is for not to forget about the guideline. So no confusion. See, instead of getting treated with COVID and all confusion in the hospital, keep away COVID. Simple way, follow these principles. So once again, hearty welcome to each and every one of the delegates, and thank you for your very good response. And once again, I thank our team for organizing this, including the Dean, Dr. Bairi, and all the best, and have a nice time. Thank you so much. Yes, Dr. Bairi.
Thank you, Dr. Rao, for nicely introducing the university and welcoming the delegates. Today we have 3 speakers. They will be speaking on infectiousness of COVID-19, decoding the mysteries of invisible enemy, and the last one is debunking COVID myths. Today's first speaker is Dr. Raza Aziz, who is professor and chairperson of Community Medicine Department of Rakcoms under RAK-MHSU. She is graduated from Qas Al Ali School of Medicine, Cairo University, Egypt in the year 1994 with excellent honor. After graduation, she joined the same college as a faculty and started her career there. She obtained master's degree in public health, preventive and social medicine in the year 2000 and medical doctorate of public health, preventive and social medicine in the year 2005. She obtained MOH license as specialist A public health in 2006 from UAE and joined RAK-MHSU in the year 2008. She had written a book chapter in contemporary issues in public health, North Africa, and a number of publications in international and national journals indexed in Scopus and other indexing agencies. Before I inviting you, a message to the audience. If you have any questions, please communicate through the chat box. The speaker will answer at the end of all 3 talks. Now I invite Dr. Raza to deliver her speech on infectiousness of COVID-19.
Thank you, Dr. Berry, for introducing me. It's a pleasure to be here with you in this webinar, and I hope we can send useful messages to our audience. My presentation is about infectiousness of COVID-19. A Chinese CDC study that included more than 72,000 confirmed and suspected cases of the novel coronavirus found that the novel coronavirus is more contagious than the related viruses which cause SARS and MERS. So what are the factors which determine the infectiousness of COVID-19? How do we measure infectiousness of COVID-19 and how to reduce infectiousness of COVID-19? This will be the presentation outline. But before starting, let's have an overview of coronavirus and COVID-19 pandemic. Coronaviruses are a group of RNA viruses that can cause illness in animals or humans. They often circulate among animals, but sometimes can infect people. They were first identified in the mid-1960s. 4 groups were identified: alpha, beta, gamma, delta. Group beta is mainly causing the human illness, mainly severe human illness. Over the past 2 decades, coronavirus have received a wider recognition when it caused an outbreak of SARS in the year 2003 in China and Hong Kong. And another outbreak took place in Saudi Arabia and United Arab Emirates and other countries called MERS in the year 2012. In the year 2019, coronavirus became a household name all over the world, causing the ongoing pandemic of coronavirus disease 2019. COVID-19 is caused by the virus SARS coronavirus 2, which is similar to the virus causing the disease SARS coronavirus 1, but this one is more sticky than it, and this helps the virus to invade the cell rapidly and spread throughout the body. The outbreak was first identified in Wuhan in China in December 2019 and rapidly spread to many countries in the world. The World Health Organization declared pandemic on 11th March 2020. Immediately, the first WHO strategic objective for this response is to interrupt human-to-human transmission to reduce secondary infection. The infection is spreading mainly from person to person through coughing, sneezing, and possibly talking and breathing. It is primarily spreading by large respiratory droplet more than 5 micron that landing on the mucosal surface of the mouth or nose or eye. It is also transmitted by contact, whether direct contact with infected individual or indirectly through touching contaminated surfaces with the virus and then touching mouth, nose, and eyes. The virus can survive on these surfaces up to 3 days. A scientific debate about the airborne transmission in which tiny particles less than 5 micron during talking can remain suspended in the air for longer period up to hours and even can travel for a longer distance up to meters and maybe room scale. In this debate, the New York Times reported 239 experts from 32 countries claimed coronavirus is airborne and published an article entitled, "It is the time to address airborne transmission of COVID-19." And they are advocating for the use of preventive measures to mitigate this route of airborne transmission. Of these measures, masks may be needed indoors, even in socially distant settings. Ventilation systems should be provided with powerful new filters. Germicidal ultraviolet light may be needed to kill these tiny viral particles suspended in the air. And most importantly, to avoid overcrowdedness, specifically in the public building. The WHO official said it is reviewing the new evidence and would provide the update on the topic in the coming days. Now the question is whether airborne microdroplets are a significant pathway for infection. significant enough to warrant changes in the WHO guideline? In fact, we are looking for the force of transmission that is driving the epidemiology of an outbreak, which is infectiousness of infectious disease. Infectiousness measures how will an infection spread, and this depends partly on the organism. Different infectious organisms have different risk of transmission if there is contact. And for different diseases, people will remain infectious for different lengths of time. It also depends on the environment, because that will determine the probability of contact, the time and number of contact in the population, which vary from population to population. Most importantly, how will it spread is human behavior, and whether there any prevention measure in place. So we can say infectiousness not only vary from disease to disease, but between population and even in the same population over time, depending on what we call the contact pattern. Now let's look at the coronavirus progression in the majority of cases. When an individual exposed to the virus, even low infectious dose can cause the infection. The time between exposure to the virus and the development of the symptoms is about 2 to 14 days. We call it the incubation period. And it answers a question, how long does it take to get sick? And for individuals who are exposed to infected one, they can do self-quarantine for 14 days. After the person develops the symptoms, the illness will take 10 days, but it can be longer, depending on the viral load. The higher the viral load, the longer the duration of illness, and maybe the severe is the case. But how long are you infectious? An infectious period from 8 to 10 days. It starts in the last 3 days of the incubation period, during which the individual is not aware of being exposed to the infection, and extend up to 1 week in the course of illness. But it may be also be longer, depending on the viral load. Now, what is take for an epidemic to spread in a population? Only a single susceptible individual get infected by the virus. Susceptible mean individual not exposed to the infection before or received a vaccine of any disease. So first, only one individual is infected by the virus. And then this infected individual needs at least one other person to spread the virus in the population. Once an individual infects more than one individual, then the number of infection will increase exponentially, and epidemic will take place. The number of cases will continue to increase until the epidemic will reach a peak, and then the case will slow down. The course of epidemic in COVID-19 depends on a number of key epidemiological factors, which make it more infectious than any other related virus. First, the pre-symptomatic infectiousness. The infected individual continue to shed the virus to the surrounding during the incubation period, and he is not aware of being exposed to the infection. Therefore, early surveillance and control are crucial. Second, asymptomatic cases. Unfortunately, 80% of COVID-19 cases are asymptomatic or mild, and infection may pass unnoticed. In this situation, symptom-based control is not enough. Can you tell if someone is pre-symptomatic or asymptomatic? The bad news, no. Until the pre-symptomatic become symptomatic or asymptomatic discovered accidentally during laboratory investigation. Lastly, the length of infectious period for COVID-19, which remain uncertain, but it may last for 10 days or more. How do we measure infectiousness of infectious disease? By what we call R0. R0 was described as the messy metric that may soon shape our lives. And a question raised in the New York Times, when might society begin to reopen, referring to the Paris metro? And the answer was a single metric may play a big role. So what is R naught? R naught is the case reproduction number, or the number of secondary cases per case. At the beginning of the outbreak, when all the population are susceptible, we call it the basic case reproduction number. As the epidemic progresses, we call it the effective case reproduction number. It is changeable over time because people become infected and intervention are used. So what do you mean by R naught 4 and R naught 1? Let's understand together what is the meaning of this. R naught of 4 means one infected individual will transmit the infection to 4 susceptible individuals. And this 4 secondary case will in turn infect 16 individuals. And this 16 individual will infect a further 64 individuals. And the replication will continue until the whole population is immune, either by past infection or by the intake of the vaccine. Whereas R naught of 1 means only one infected individual transmits the infection to only one susceptible, and this secondary case will transmit the infection to another only one individual, and so on. So what do R naught value mean? When the R naught is less than 1, this means the number of cases is shrinking, and this allowing society to open back up. But if it is more than 1, this means the number of cases is growing, and perhaps it may need renewed lockdown or other measure. In fact, we are looking for R naught less than 1. So what is the R number of COVID-19? According to this study, the novel coronavirus 2019 is highly contagious and more infectious than initial estimated. The initial estimate for COVID-19 virus R naught was 2.2 to 2.7. But the number of infected individuals during early epidemic doubled every 2.4 days, and the R naught value is likely to be between 4.7 and 6.6. In another study published in Emerging Infectious Disease in July 2020, also estimated the R naught at a median of 5.7. This means SARS coronavirus is highly contagious than seasonal flu, which have an R naught of 1.3, and even more than SARS, but less infectious than the common diseases we are aware about them, measles and mumps. The good news, R naught is not fixed. It is affected by the density of the population, the proportion of susceptible people at the start, and the infectiousness of the organism. So the denser the population, the larger the number of susceptible people at the start, the higher the infectiousness of organism is, the larger the R naught. Whereas the faster the rate of disappearance of cases by recovery or death, and the more the prevention measures are in place, the smaller the R naught. If the R naught is more than 1, this means that the number of cumulative cases will take off. But if it is below 1, this means we will be about to finish the outbreak. Let's see how does it work. Say a disease has an R value of 1.5. This means 100 people will infect 150, who would in turn infect 225, who would infect 338, and so on, until the number of cases will increase and the result will be exponential growth. On the other hand, say an R of 0.5 means 100 people would infect only 50, who would infect 25, who would infect 13, and this will continue until we reach 0 case and end of the outbreak. And some countries succeeded to push their R naught down to less than 1, and it was a huge achievement, won at a heavy cost. What is important to say now, if people start losing patience with restrictions, the R value could quickly rise. R naught also predicts the proportion of population that has to be immunized. to prevent sustained spread of infection in the population using a certain equation. So we can say with an R naught of 5.7, we are in need for 82% of the population to be immune to COVID-19 to spread its transmission. This is frequently asked question. Can people who recover from COVID-19 be reinfected again? In fact, the immune response and the duration of immunity to SARS coronavirus 2 is not yet understood. But the rapid spread of SARS coronavirus 2 raised the possibility that mutation make it more able to evade the body's immune system. And this will leave the patient susceptible to second infection. Not only this, but also it will be questioned the implication for vaccine development. How to reduce R naught? Stay safe at home as much as you can. This is number one. Follow cough etiquette. Maintain social distancing within 2 meters. Use face mask. Wash your hands thoroughly for at least 30 seconds. And use of personal protective equipment at the healthcare setting. If we use the protective measure, we can flatten the curve. And history shows it is really possible. During the Spanish flu epidemic 1918, some cities in the United States were much faster with canceling events, and that saved a lot of lives. As you see in this image, Philadelphia waited for 2 weeks to take protective measures, whereas St. Louis waited only for 2 days. And the result, the number of mortality in St. Louis is smaller compared with Philadelphia. Also in this image, you can see how the lockdown in UK in the year 2020 reduced the infection rate from around 4 up to less than 1. So please do your part to reduce the R naught, and remember, panic is our enemy, knowledge is our friend, and preparation is our best line of defense. Thank you.
Thank you, Dr. Rasha, for that excellent and clear talk. As mentioned earlier, we will take up the question and answer session at the end of all the 3 talks. The next speaker is Dr. Raghavendra Bhatt. Dr. Raghavendra Bhatt is Professor of Internal Medicine at Rakk College of Medical Sciences. Before joining Rakcoms, he was working as Professor and Head of Medicine at Kasturba Medical College, Mangalore. He received 5 gold medals during his medical training. He is an excellent teacher, clinician, and researcher during his 3.5 decades long experience. He is a passionate teacher, contributed by doing teaching. He has published over 30 research papers in national and international journals and published 6 medical books. Was written using his own personal experience. In his earlier career, he was a PG teacher and has guided over 30 students for their MD thesis. He has participated in many CMEs, conferences, and workshops. He is an advisor for the most widely read textbooks of internal medicine and some journals for internal medicine. He is a blogger and blogs about anecdotes related to history and practice of medicine. Happily married, has 2 daughters. One is an oncologist and the other one an ophthalmologist. He is going to speak on decoding the mysteries of invisible enemy. As all of you know, that it was American President Donald Trump who called the coronavirus an invisible enemy that is brilliant, tough, and smart. Now I request Dr. Raghavendra Bhatt to deliver his speech.
So good afternoon. It is my good fortune and pleasure to be here and say something that we definitely know about this disease. To begin with, what do we know? If I were to chart confidence on the x-axis and knowledge on the y-axis, at the beginning, what is coronavirus? We know everything about it, nothing to worry. After some time, we found people dying out of it in large numbers, particularly Italy and New York. And we thought, okay, we are never going to understand this. After about 3 months, we started understanding that we didn't know, but we are now knowing something about it, and we started handling it better, and it started to make sense. After 6 months, we are now knowing more about it, and trust me, it is complicated. I begin with one most important single message that has to go with every talk, and that is we can only prevent it. At the moment, treatment is variable and not certain. Now, prevention is possible by intelligent means like wearing mask, washing, distancing. If you don't get at the enemy, if the enemy can't get at you, you won't get the disease. Simple, basic. I don't want to talk long about it. The picture over here shows you without mask and with mask. Without mask, the culture is full of organism. With mask, very few. So you get a much less chance. I opened my talk with this picture. This is the only picture I've used twice. And the second time is a zoom showing you that it represents hundreds of doctors all over the world who lost their lives saving ours. There are a few who is not visible here because there are hundreds. I've shown a few random ones where they are identifiable, and sadly, we lost them. This is my moment of my pride. These are the students from Rakcoms at the forefront. They are the real COVID warriors. We might have taught them, loved them, judged them. We might have seen what this student will do. What we never imagined and what they did is they became the COVID warriors for UAE, taking the heights of our Rakcoms to a new level, new glory. Hats off to you, proud of you, and may you do better in future. Not to wear a mask is rather bad. There's two types of sins. One is a venial sin. A venial sin is denial, ignorance. The person doesn't know, he's not educated, he doesn't know what to do, cannot afford a mask, can't access a mask. Well, he's forgiven. The second one is a mortal sin. Willful ignorance. He knows that he has to wear a mask. He has a mask. He has access to mask. Yet he doesn't wear a mask, doesn't wash hands, goes intentionally to places which are crowded. And this is called the mortal sin. Let us not do the sin, the mortal sin. Over here on the right side, I'm showing you a picture of a person carrying a donkey. This picture looks absurd. Why is a human being carrying a donkey on his back and moving? Well, this represents the Second World War. This area was full of mines. And as you know, mines is the area where you walk into them, it will explode and kill everyone around that area. There was a donkey running about. And donkey being a donkey was going anywhere without any hesitation. To save themselves, the soldier preferred to carry the donkey. This is the problem. The donkey looks higher than the soldier. The donkey looks more important, but it's not being carried because it's important, because it's the hazard. This is the hazard that the people who do not follow the social norms, social distancing, are posing to us, but we will have to carry them to protect ourselves. And please understand, you can never, ever have a lack of oxygen wearing a mask. Size of the virus is 0.125 microns. Size of the oxygen is 0.0005 microns. It will move freely in and out of your mask of almost any type. Coming to the actual enemy, you see the picture of the enemy over here. This is our enemy, beautiful one. It has got nice spikes. It has got certain protective shell over there. It has got the coil RNA, is very important for its multiplication, and it has got the proteins, E protein and M protein. In other words, it's simply an existing substance with RNA and a coat. That's all. And it is armed with a few things which it needs, with which it's creating a walk. Now we have a very intricate lock. That's the receptor, ACE2 receptor, a very intricate lock which only a specific key can open. And most interestingly, this enemy of ours has come with the perfect key for the lock, and it has got its machinery geared up, and it can do any havoc. Now, we all have seen children doing homework. If they have a homework of 2 pages, they do it well, and the mistakes are few. If it is a 10-page homework, mistakes are more. Just like that, the SARS virus is much longer than the average RNA virus. Shown above our RNA virus, shown in red is our virus, our friend, coronavirus, much longer. More length means more genes, accessory genes. More genes means more mutations. More mutations means more mistakes. So the virus can mutate into a less or a more potent one. It can produce effects which are unpredictable and infectivity which keep changing, and the outcome keeps changing. So this is the advantage, genetic advantage it has. Now this is the inside view, a three-dimensional view of inside the coronavirus. So we quickly go understand how it comes. Now the virus has come. This is its key. It's attaching to the log AC2 receptor protein, and it's opening it. It enters inside the cell. It liberates its RNA, the coil, and it replicates. It multiplies. And it has got specific protein, N protein, which links it to the RNA polymerase enzyme, helping it stabilize the RNA. Now, whatever instrument it has is stable. It can be used well. Finally, it has got E protein and M protein, with the help of which it breaks open and destroys the cell that it has entered, the lung cell most of the time. And the cell that is entered, what it does, it uses the cell machinery to replicate. One virus becomes hundreds of viruses. And after that, it damages the cell and comes out. So the cells infected die, and the virus has multiplied. This takes about 10 hours from the entry point. Now, body is not keeping quiet. What does it do? It produces a substance called interferon, which is antiviral. And it recruits the immune system, the T cells and B cells. The T cells directly kill. They're like soldiers. They directly go and kill the virus. And sometimes what they do is they kill the lung cell containing the virus, whereas the B cells produce antibodies. These antibodies neutralize the virus. They come attached to the spike protein and make it ineffective. Very interestingly, the virus has already anticipated it. That's when we say enemy is intelligent. It has come with proteins which can bind the sugar molecules, preventing the antibodies from coming and attaching. And now, yesterday, there was a report of camouflage that is caused by the virus, because of which the immune cells cannot identify it. This is a fundamental advance. It can mask itself. These terms, you know, I won't go into it. I just want to say isolation is good. Isolation is for the people who are not involved, and the asymptomatic people, you do quarantine. The patients, you isolate. This is the simple way of putting it. If there is somebody who is asymptomatic but having the virus, he has to be isolated. If someone is not having anything, asymptomatic, and he has to be quarantined. So these are the two instruments that we have, and these are the two instruments which restrict the movement of people. Now, WHO is one instance, went wrong many times. This is one instance. It said that only the aerosols are not infective, but only the larger particles are infective. That means the droplets are infective, not the aerosol. One of the researchers called Nasib Taleb said, it is like calling a black swan not a swan. Whatever color, swan is a swan. Most of them are white. Once in a while they can be black. So this is what he calls a black swan theory. And after all, an aerosol is a very, very small droplet. A droplet which is big will drop down, and when it loses its moisture, it becomes tinier and tinier. It can fly again as aerosol, and it still has the virus. It can be infective. This is the new knowledge we have. This is a very busy slide, but all that I want to show is one example. There are many here. If you want to eat from outside, if you go to a bar or if you go to a buffet, you have the highest risk. If you go and eat in a small restaurant which is closed and which has got distancing, social distancing, you have moderate risk. You just bring your food from outside and eat in your home, you have the lowest risk. So every activity like this can be graded down, making it less dangerous. If you were to wear mask and the other person were to wear mask, 90% risk is reduced almost to 0%. Both wearing mask and social distancing is there more than 3 to 6 feet, no risk. Whereas if both are not wearing mask, it's 90% risk. Now we come to the enemy proper. The first phase of infection is the virus-related replication. Second phase is the immunity starts working. This is interesting. Initial immunity is the T and B cell. Later, there is an involvement of other structures like platelets and immune dysregulation. The first cell to come is a neutrophil. It will have two methods of destroying the enemy, hug and swallow. Second one, degranulate. Degranulation is an angry response. It not only kills the enemy, it dies and it destroys the tissues around. So more degranulation, more danger, and it produces cytokine release syndrome, and it can activate macrophages, producing macrophage activation syndrome. So these things, cytokine release syndrome, macrophage activation syndrome, can produce multiple organ failure. What happens in the lung can happen in other organs also. So heart, kidney, and brain can be involved at the same time, but to a lesser extent. So if someone asks, what are the two important organs involved in COVID? Only two. One is lung, the site of entry. Second is the blood vessel. Because it is the endothelial damage, blood vessels of all organs can be involved. So because the blood vessel is involved, other organs can be brain, or heart, or kidney, or anything. This is the second. Then you have the change in metabolism. It's not a simple thing. It changes the type of metabolism at the level of macrophage, and activated macrophage cannot use the acetyl coenzyme pathway. Instead, it continues, the pyruvate cannot become acetyl coenzyme, it can only become lactate. So there is more lactate production and there is more acidosis. This is the sum and essence of what is called macrophage activation syndrome, which is the other reason for destruction. So you have the cytokine storm, and the storm is the one, it is killer. But it may not be there in some patients, maybe there in some patients, maybe only 10% have the cytokine storm. And we have a lot of instruments to get rid of it. You have the steroids, the general one, chloroquine and the hydroxychloroquine, blocking the entry, IL-6 inhibitor, tocilizumab, we have colchicine, which is an immunomodulator, we have tumor necrosis factor alpha, and we have IVIG and convalescent plasma. I can show you all the gadgets at our disposal, but the time doesn't permit me to go into it. So what happens? Initially, we thought that this is the problem of hypoxia, what was called happy hypoxia. Then is the person becomes hypoxic after 7 to 8 days. After about 10th to 12th day, he becomes hypoxic, doesn't realize. Some of them drop down dead, some of them require ventilator, they don't do well. So we thought hypoxia meaning no oxygen, give them oxygen, put them on ventilator. Where did we go wrong? People started dying in large numbers, New York, Italy. Where did we go wrong? We went wrong in a place where we didn't realize not only the hypoxia is due to gas transfer problem, but also due to formation of clots because of stimulation of platelets and coagulation factors. This was brought out by one of my earlier students, Annapurna Prabhu from New York University, New York. She said that in their university, a frustrated pulmonologist who was seeing a lot of people die met a frustrated nephrologist in a canteen and said, my patients are clotting in the kidney. And the respiratory man said, my patients are clotting in the lung. This is how the science advances. And they realized that the problem is not only in the oxygen transfer, but also the formation of clots. Heparin came into the frontline treatment. Anticoagulation was started. How do we assess severity? We go by the markers of inflammation like D-dimer, ferritin, IL-6, and obviously, it's asymptomatic patient, less dangerous, more symptomatic, more dangerous. We go by the oxygen saturation, hypoxia, more dangerous, can't breathe, even more dangerous. Saturation drops. But do we have flus in simple test? Yes, we do have low eosinophil count, low lymphocyte count, high neutrophil count, low platelet count are danger signs. So we have only, speaking of lungs, initial 2 months we only saw the lungs. What is happening in the lungs to a lesser extent is happening in other organs like heart, like kidney, like brain. Heart can have arrhythmias, embolism, heart attack, stroke. Why? The same endothelium is having, blood vessels are having the same endothelium, and damage in endothelium can be anywhere. When organs like heart, brain, and kidney are involved, the endocrine organs are not far behind. So you sometimes have pituitary failure, thyroid failure, adrenal failure, giving rise to further complications. It can sometimes we find a very interesting phenomenon. Non-diabetic or a pre-diabetic becomes extreme diabetic, goes into ketoacidosis. Why? Pancreatic failure. It's an endocrine organ. Vessels there get damaged, they go into endocrine failure. So there is a paradoxical precipitation of diabetes, exacerbation of diabetes, and production of ketosis. So in other words, virtually any organ can be involved via wiser. Though it's mainly the lungs and thromboembolism, there can be involvement of heart, liver, GI tract, skin, endocrine, or nerves. Person come with stroke. So many times the patients will come with stroke and they get treated. After they die, COVID test shows positive. They say, did COVID cause the death? The thing is, COVID might have been an incidental finding, or it may have produced this complication. Now all the tests are done in the beginning itself. Sometimes we find serious brain damage after recovery. Sometimes you find the loss of taste sensation. The person has flu-like picture, no taste, very common. All of us have experienced this in many viral illnesses. But if a person of COVID has lost his taste and smell, is good news. They have less complicated disease. Now coming to the diagnosis, this is something that I want to touch upon a little longer than what is shown here, that a PCR, polymerase chain reaction, is the test done. It isolates and amplifies the viral RNA. It was started by this gentleman, Kerry Mullis. Very interestingly, Kerry Mullis is very upset that this is being used as a diagnostic test. The problem is, the most interesting thing is, it only says there is RNA. It doesn't tell you whether it is infective, RNA in the beginning, or it's a dead RNA, which has remained there because it is yet to be removed by the system. In other words, a positive test of PCR is a marker of exposure. It's a marker of possible early disease, possible infectivity in the first week. But if it is present after 10 days, 14 days, it doesn't mean second infection or doesn't mean it's still infective. It means now called lingering RNA. It's called as the compounding effect. This is just coming, CDC has just announced these terms a couple of days back. So you have the other test, antibody. How can we use together? Anytime PCR is positive in the first week, asymptomatic or early symptoms, it is an active disease. PCR positivity with IgM positivity is early disease. PCR negative with IgM and IgG positive is a person has had the disease. Only IgM is positive, you have not done PCR, likely to be early infection. IgG is positive, it's likely to be late infection. Sometimes at the end of it, the whole thing can disappear. So in a nutshell, PCR is evidence of exposure, possible early infection. And antibodies tell you there's a surveillance. They have been exposed or not, infected or not. Okay. Then you have the X-ray and the CT scan, which are extremely important parameters. You have what is called ground glass opacity. Shown here, ground glass, that is the presence of an opacity through which you can see a vessel clearly, or a crazy pavement sign, wherein you have a septate seen very clearly inside the lesion, or you have a reverse halo sign. These three are the classical signs of CT scan. And you can grade the severity by the extent of the lesion. There are calculations there. I won't go into it. It's a classical picture of a COVID ARDS, respiratory distress syndrome. This is thanks to my old student, Dr. Alam Nawaz from India, Bangalore, my old institute. And these X-rays are non-COVID patient. These X-rays are COVID patient. So when the disease spreads very fast and seems to be very rapidly increasing, and the test is negative and the neutrophils, this is non-COVID. So please remember, even in the COVID situation, there are non-COVID causes producing similar changes. We have to carefully go through these things and sort it out. A very important for us to know that some of the people who got lung damage, the lung is so seriously damaged. You can see the lung here. This was later transplanted by Dr. Bharat. It's the first lung transplant that was done for COVID patients. You can see how the lungs have holes. This is a few days of infection. You can imagine how destructive it can be, the virus, if it chooses to be. Coming to the drug and vaccine options. Now, what options do we have? As I told you, it enters, it has a spike and attaches. So can we stop this attachment and entry? Yes, we have hydroxychloroquine and chloroquine. Can we stop this viral polymerase? Can we shut down the virus as a whole? This viral polymerase can be stopped by remdesivir. Now, can we shut down the virus as a whole and prevent the vesicles from forming? Can we, even if we can't do that, and if a virus does progress and irritate the immune system for a hyperimmune response, can we stop that? Yes, we can have. We have the armamentarium of giving oxygen, giving other substances like interleukin-6 inhibitors. We can use steroids. This is very interesting. Corticosteroids are this most important organ and therapeutic armamentarium we have. Dexamethasone, methylprednisolone, excellent. They give very good results given at that time. So please understand, these have to be given at that time to give the excuse me, presentation. Presentation. Okay, so sorry, the immune system, which is working extra, can be suppressed by corticosteroids. Dexamethasone is the most important thing that we have. Very interestingly, we are getting reports from Texas of the use of budesonide. We use this budesonide nebulizer for day-to-day use in asthma. Used early, this is supposed to be very good and it's worth trying. Whereas dexamethasone will not work in the beginning, it's only later. So now after 3 to 6 months, we know this, and this is why we are having less deaths. Viral replication, there is a role for symptomatic treatment and antiviral. Early damage, there is a role for oxygen and high flow oxygen. We don't put them on ventilator. We give heparin, we give steroids when needed. Only the people who don't respond to all this, they go to ventilator. So we have much more survival, we are wiser. Coming to the vaccine option, you have the antigen presenting cell, which takes the antigen to the helper T cell, and the helper T cell identifies this, and it can either kill it or it can tell the B cell to produce antibodies. Antibodies such produced in that way will go and attack the virus and neutralize it, or you can neutralize the spike. So this is the way they work, and when this works, and this is remembered for a long time, this is the effect of virus. So it's exactly like the virus. You're doing the same thing, virus and the attenuated virus in vaccine. Then what is the difference? Here it is the attenuated virus. It has lost its potency, and the effect is to block the spike protein so that it doesn't come and attach. You are changing the lock. Key remains same. The lock is modified. So we have to understand that because it is the modification of lock, if we don't do the job perfectly well, our modification may help the entry rather than block the entry. This is why vaccine trials should be done extremely carefully and tried for a long time. Stage 1 trial is going on, stage 2 trial is going on. In India, Zydus Cadila is doing the stage 2 trial. Now they've taken up 1,000 subjects, and they're in close touch with me, and likely that they're heading for a successful vaccine. So these are the various vaccines that are being used and being done. The platforms are different, and the stage at which they reach is different. So it doesn't seem to be possible before February, we may not have a vaccine. Very interesting to know that psychotherapy, if you tell someone, don't worry, if you make someone believe that you won't get the disease if he takes the distancing, Even if he gets the disease, he can come out of it if he's taking care, they do well. This is extremely important. Immunity doesn't depend only on the vitamin D or the tablet that you take, but it depends on your nutrition status, status of general health, which is maintained by exercise, fresh air, good thoughts, positive thinking, and good immunity. So immunity is the sum and essence of what we are, how we behave. Stay positive thoughts, think well, eat well, and think that good things are going to happen to you and others. You will overcome this enemy like no other problem. This is from Tamil Nadu. My old student Ajay Mohan told me that most of the time the deaths are at night. Why the deaths are at night? Because the corticosteroid levels are the lowest at night and the melatonin levels are highest at night. Corticosteroids are our friends. Melatonin is our enemy in this disease. So the highest deaths at night happen when the patient is least awake and the oxygen levels and steroid levels are at lowest. We have the deaths. The deaths are definitely low compared to other causes. Should we ignore? No, because these deaths are highly preventable if taken care. And good people die, though the deaths are very few. They being preventable, the loss for the family is 100%. We don't want that. In recovery, we teach them diaphragmatic breathing and sometimes incentive spirometry. There are a lot of misconceptions. People started eating datura seeds thinking that they resembles coronavirus or datura poisoning. Some of the people ordered culling of the mink saying that they have coronavirus. This is a one-page summary of what is happening. The pandemic alert, community transmission, the diagnosis, evaluation, early infection, we have the answers of symptomatic treatment and antiviral, pulmonary phase, we have oxygen, hydroxychloroquine, azithromycin. In critical phase, we have got corticosteroids and heparin in the stage of thrombosis. This is here. And corticosteroids and other high-five things in the critical phase, and in stabilization phase, we teach them rehabilitation. At the end, I have a message. The 11th commandment, you all know 10 commandments. 11th commandment is, you shall not COVID your neighbor's life. You don't want to wear a mask, don't go to the house. It's fine. You think it is an option, please don't go to the house. Because you don't wear a mask, you don't do distancing, you go out of the house, you are a danger to your own kith and kin, your own loved ones, and your unsuspecting neighbors and others. This is what message to the students. I will teach you in a room, I'll teach you on Zoom, I'll teach you in your house, I'll teach you with a mouse, but I will teach you. And I here and there, and I will teach because I care. This opened new dimensions. Today, the faculty is in a much better position to teach. We can teach very well. We can teach with the online abilities. And today, the students are doing much better. I'm appreciating the freedom they get. They can sit anywhere, eat, drink, see, walk about, and learn. And I'm finding more response from the students for learning than ever before. Hats off to them. And this is the state of affairs. This conference, people used to sleep in between others, and in webinars, they're sleeping on their own beds. This is what has happened. The webinar incidence has gone above the corona cases. Finally, if the CV has to be made by the coronavirus, we'll ask him to write his CV. What will he say? What will we say? Is responsible for global digital transformation. It reduces the global carbon dioxide emission. It has got improved the global hygiene initiatives. It's ensured 100% compliance with the hand washing and distancing. It has made the industry shift to measures which are safe, and work from home is the norm now. And it has reduced noise pollution, electricity consumption. It has taught many people like me cooking, vegetable shopping, and housekeeping. Today, I can cook a good meal thanks to coronavirus. It has provided ample time and all egoistic, self-centered people to contemplate on their mortal nature. We are all mortal. We have now better family bonds. It has given big boost to certain family sector, pharma sectors, and it has highlighted the importance of governance, adaptability, and long-term planning by all sectors. I'm sure coronavirus CV is looking better than most of the other CV. It changed us forever. I don't think in short future, the life will become same again. I thank all of you very much. I also thank the university, our beloved president, Dr. Guru Madhav Rao, and our dean, Dr. Bairi, and all the other faculty. We are like our Rakcoms family for the opportunity given.
Thank you, Dr. Raghavendra Bhatt, for that exceptional speech. Our next speaker is Dr. Amina, who is an associate professor of pharmacology at Rakk College of Medical Sciences, Salkaima. She graduated with an honor degree in the year 1993 from Faculty of Medicine, University of Alexandria, Egypt. In 2004, she got her master's degree in pharmacology from University of Alexandria and appointed as lecturer of pharmacology. In 2009, she got her PhD in pharmacology, which was conjoint work between Alexandria University in Egypt and Augusta University, USA. She was promoted as assistant professor of pharmacology. Before joining Rakk MHSU, she was working at Faculty of Medicine, University of Tabuk in Saudi Arabia. She has attended many international conferences where she has presented her scientific research papers and has published many articles in national and international journals. Now I invite Dr. Amina to deliver her speech on debunking COVID myths. Dr. Amina, please.
Hello, everybody. Good afternoon. I feel so happy that I can give you such a webinar. Okay. So let's start. My webinar today is about debunking some of the myths about the COVID-19. So we are going to say about the things that some people know and they are not true or they are not right. So, and we are going to discuss what is the fact about those myths. So our discussion today is based mainly on the guideline of the COVID-19 panel and the WHO recommendation. So what is the COVID-19 panel? Members of COVID-19 treatment guideline panel were chosen based on their clinical experience, expertise in patient management, clinical science, and development of treatment guideline. The panel members include representatives from federal agencies like NIH, healthcare, academic organizations like CDC, and professional society. So what about the first myth? The first myth, there exists an approved pharmacotherapy for COVID-19. And you know, COVID-19 stands CO for corona, VI for virus, and D for disease 19, because it was discovered on 2019. So there exists an approved pharmacotherapy for COVID-19. The fact is, there is no FDA-approved drug for treatment of COVID-19 till now, except for remdesivir. Remdesivir is an investigational antiviral drug that inhibits viral RNA polymerase. This drug is available only through FDA emergency use authorization. That's to say, it is only used for certain cases, not treatment for all the cases of COVID-19. It is only used in patients with severe COVID-19, hospitalized. It is given only for 5 days. And what is its effect? It reduces the time to clinical recovery. Why they are using it only for 5 days? Because it has some effect on the liver. It causes a problem in the transaminase enzyme. So this is why it is given for short period and it is given in the hospital. The second myth is about some vitamins or supplement that can be given in a treatment of COVID, like zinc. Why they put zinc in the treatment of COVID? Some studies showed that increased intracellular zinc impairs the replication of a number of viruses. And this now going on clinical trial using zinc for COVID. What is the fact? The fact we don't have sufficient data to recommend either the use for or against zinc treatment of COVID. The panel recommend against using zinc supplement above the recommended dietary allowance. What is the recommended dietary allowance? For men, it is 11 milligrams per day, and for women, 8 milligrams per month. This are the recommended dose that can be used by any person, except in a clinical trial they are using a higher dose. Why they insist about using this dose only? Because long-term zinc supplementation has led to many adverse effects like copper deficiency, reversible hematologic defect like anemia, leukopenia, and potentially some irreversible neurological manifestation, myelopathy, paresthesia, and ataxia. So you should have to take good care when you are going to choose your vitamin from the pharmacy to check if the zinc concentration is suitable. Another important myth is about vitamin C. As we all know, vitamin C is used in any person who has a common cold. He go to the pharmacy, he buy vitamin C. So why they are thinking that a high dose of vitamin C can be used in the treatment regimen for COVID-19? Some studies have shown that high dose of vitamin C causes amelioration of the inflammation and the vascular injury in patients with COVID-19. What is the fact? The fact there are insufficient data for the COVID-19 panel to recommend either with or against the use of vitamin C for the treatment of COVID-19, especially in this large dose. And several trials are going on now to show if we can use oral or intravenous vitamin C in people with COVID-19. Some hospitals are using large dose of vitamin C till now in the treatment regimen of COVID-19 in a dose of 1 gram per day. Sometimes they increase it to 3 grams. The importance, this high dose have also side effects. They can lead sometimes to stones. They can lead to the level of glycosylated hemoglobin can be misleading when you are going to take a high dose of vitamin C. So it is better if you're going to stick to the normal daily dose or the highest dose that can be given, which is 1 gram per day. The third myth is about vitamin D. They said also vitamin D can be used as adjuvant in the treatment of COVID-19. This was based on studies that show that vitamin D can cause modulation of the immune system, and this can protect against COVID-19 or decrease the severity of illness. But what is the fact about that? The fact we don't have sufficient data to recommend either they use it or do not use it. And there is ongoing observational study to evaluate the role of vitamin D in preventing and treating COVID-19. The next myth is about the non-steroidal anti-inflammatory drugs. As all we know, when the COVID-19 began, the pandemic, they said, okay, stop taking everything non-steroidal anti-inflammatory drug, just take paracetamol. Why? Because they said that all non-steroidal anti-inflammatory drugs, except paracetamol, could aggravate the condition of COVID-19. This was based on news agencies that promoted reports that anti-inflammatory drugs, except paracetamol, can worsen the COVID-19 patient status. How? They propose that non-steroidal anti-inflammatory drug like ibuprofen can increase the expression of angiotensin converting enzyme 2. What is this angiotensin converting enzyme 2? This is the enzyme to which the COVID virus go and stick when it enters the body. So they say those non-steroidal anti-inflammatory drug, except paracetamol, can increase the expression of this enzyme or this protein, and hence they are going to increase the disease condition of the patient, and they are going to inhibit the antibody production. But what is the fact? The fact is, what the panel have said that the person with COVID-19 who are taking non-steroidal anti-inflammatory drug for any comorbid condition, they should continue the therapy as previously directed by their physician. And they recommend there is no difference in the use of antipyretic steroids, whether you are using acetaminophen, this is paracetamol, or ibuprofen, or Voltaren, between patient with or without COVID-19. So you can use any of the non-steroidal anti-inflammatory drug. Let's talk about this. What is this angiotensin converting enzyme 2? Like I've told you, or you can see from here, from the image, this is the virus, and this is where it go inside the body. It binds to the angiotensin converting enzyme 2, and this binding is going to facilitate its entry. This angiotensin converting enzyme 2 is not expressed only in the lung, it's expressed throughout the body, including type 2 pneumocytes, myocardial cells, cholangiocytes, enterocytes, and oral mucosal epithelium. When there were studies saying that the virus is attached to angiotensin converting enzyme 2, many of the scientists went to discover if other drugs or available other drugs who act on this angiotensin converting enzyme 2 can have an effect on SARS, on COVID-19. So they study all the other drugs that can have a mechanism of action relying on effect on angiotensin converting enzyme 2. Between them are the drugs which are used normally for treatment of hypertension and heart failure, like angiotensin converting enzyme inhibitor like Caboten or angiotensin receptor blocker like Diovan. They say if you are going to take those drugs, they may aggravate the COVID-19. This was based on the theory that those drugs, ACE inhibitor or ARBs, they could increase the expression of AC2, which is the binding site of SARS CoV-2 expression in the lung, and previous study showed that increased kidney and heart expression in selected experimental animals, increasing the risk of acquiring a COVID-19 infection. And so many people started at the beginning of the pandemic to stop taking those drugs. But what is the fact? The fact is the panel recommends that persons with COVID-19 who are prescribed ACE inhibitor or ARBs for cardiovascular disease, hypertension, heart failure, or any other indication, they should continue this medication because there is no proven studies to say that they have to stop this drug. And then another studies appear on the contrary. They say this may say that angiotensin converting enzyme inhibitor and angiotensin receptor blocker can be used in the treatment of COVID-19. How this comes? This is based on some study saying that those drugs are going to attenuate, decrease the level of angiotensin 2. When they are going to decrease the angiotensin 2, they are going to decrease the acute lung injury, decrease the fibrosis by reducing the action of angiotensin 2, increasing the inflammation and the death of cells in the alveoli, which are critical for bringing oxygen to the body. What is the fact about this? The COVID-19 treatment panel recommend against the use of ACE inhibitor or ARBs for the treatment of COVID-19 outside the setting of clinical trials. There are now clinical trials discovering if they have a beneficial effect or not. Another myth concerning drugs that affect also the angiotensin converting enzyme 2 are the statins. The statins are the group of drugs given to treat hyperlipidemia and hypercholesterolemia, like Lipitor. They say, oh, these drugs have an effect also on angiotensin converting enzyme 2. Can those drugs be used for treatment of COVID-19? Those drugs, they affect the angiotensin converting enzyme 2 as a part of their function in reducing the endothelial dysfunction. And studies have reported that statin therapy reduced cardiovascular morbidity in patients admitted with other respiratory tract infections such as influenza or bacterial pneumonia. So what is the fact? The fact is persons with COVID-19 who are prescribed statin for the treatment of prevention of cardiovascular disease should continue this medication. However, the panel recommends against the use of statin for the treatment of COVID-19 outside the setting of clinical trial. This is because, as we all know, the statin have major side effects on the liver, on the muscles, and they can produce many side effects and many drug interactions. So till now, we cannot use them as a treatment for COVID-19. Another important myth is they are saying that COVID-19 is the virus. Could we use any other antiviral drugs like the antiviral drugs used for AIDS, like protease inhibitor, lopinavir or ritonavir in the treatment of COVID-19? And some in vitro studies have shown possible inhibition of the enzyme protease, which is present in the virus particle. The fact is the panel recommends against the use of those drugs for the treatment of COVID-19, except in clinical trial. Why? Because they discovered they have associated toxicity, like they can affect the liver, increase the transaminase level, they can affect the heart, causing arrhythmias like QT interval prolongation, torsade de pointe, and PR interval prolongation, and they have a high drug interaction potential. So they cannot be used till now, except in clinical trials. One of the important myths that started at the beginning of the pandemic was the use of hydroxychloroquine and chloroquine in the treatment of COVID-19. Hydroxychloroquine and chloroquine, those are FDA approved drugs. To treat what? To treat malaria. Hydroxychloroquine is approved also to treat lupus and rheumatoid arthritis. On March 28, 2020, the FDA issued an emergency use authorization, like the one for remdesivir now, for those drugs to treat adult and adolescent hospitalized with COVID-19. Why they give this authority? Because there was study where those drugs shown an in vitro antiviral activity by they interfere with the virus fusion, virus glycosylation, and they have an effect on the immune system, which cause a reduction in the pro-inflammatory cytokines. But what happened in June? In June 15, 2020, the FDA removed or revoked this authority, and the panel then recommend against the use of those drugs in the treatment of COVID-19. Why? Due to associated cardiac toxicity. They can cause prolonged QT interval, torsade de pointe, AV block, and severe ventricular arrhythmia. This is why they have stopped using those drugs in the treatment of COVID-19. Another important myth, some treatment plans included the combination of hydroxychloroquine with azithromycin. Why they included azithromycin? And azithromycin is an antibiotic, and this is not a bacterial infection, this is a viral infection. Some study, they have found an action for azithromycin in the COVID-19. It has an antiviral effect through attenuation of the viral replication. It can have an effect also on the immune system. It causes immune modulation through enhancing the neutrophil activation. It has an anti-inflammatory effect through attenuation of inflammatory cytokines, interleukin 6 and interleukin 8. What is the fact? The panel recommend against the use of hydroxychloroquine plus azithromycin for the treatment of COVID, except in clinical trial. And the combination is associated with more cardiac toxicity in the form of QT interval prolongation in patients with COVID-19. However, till now, some treatment regimen of COVID include azithromycin alone without hydroxychloroquine. Another important myth is the patient who are taking corticosteroid. Patients who are taking corticosteroid for asthma or any other condition, they said, we have to stop this drug because this drug, we know that corticosteroid decreases the immunity and it is an immunosuppressant. It can aggravate the viral infection. So what is the fact? The fact is inhaled corticosteroids that are used daily for patients with asthma and chronic obstructive pulmonary disease should not be discontinued. And oral corticosteroid also used for any other disease should not be discontinued. And the most important thing, new data on corticosteroid use for COVID is appearing, and preliminary clinical trial said that use of dexamethasone reduced the mortality in hospitalized patients with COVID-19 who required mechanical ventilation or supplemental oxygen. And the recommendation for using corticosteroid depends on the severity of the illness. Before initiating the dexamethasone, the clinician should see the benefits versus the risk. Another important myth is about the test done to know that the person has an infection, he has COVID-19 or no. Some people say, do this antibody test, which is called the serological test, which are tests to discover if the patient has been taking the infection and he has made an antibody against it. And they say we can use this antibody solely to identify or exclude COVID-19 viral infection. What is the fact? The fact is, in the early days of infection, where the body immune response is still building, antibody may not be detected. So the patient can have a negative result, meaning the test for the antibody will be negative. But this does not preclude that the patient is having an acute infection. An antibody need from 1 to 3 weeks to be detected. So if acute infection is suspected, direct testing with PCR is needed. Another important thing, if you have a non-specific serological test and we discovered that you have antibody, this indicates the person has been exposed to a virus and developed antibody against it. These results can be false positive. So when you are using a serological test, this must be specific antibody for the COVID-19. Those serological tests has so many importance. They can identify the people who have antibody, and if they have antibody, we can use them for convalescent plasma, and they serve a possible treatment for those who are seriously ill from COVID-19. One important myth also, some people are asking, is pneumococcal and flu vaccine can be used to prevent COVID-19? With the fact is, vaccine against pneumonia, pneumococcal vaccine, Haemophilus vaccine do not provide protection against the new corona. Although these vaccines are not effective against COVID, but vaccination against respiratory illness is highly recommended to protect your health against those other diseases. And lastly, I have some updates on global coronavirus development to give you some good news. So according to WHO, there exist about 125 potential vaccines worldwide. 16 among them are in clinical trial, like in USA. Moderna company is developing a vaccine. They are launching a phase 3 clinical trial starting from this month. And on the 20th of July 2020, the World Health Organization uploaded newly published data by Oxford University and AstraZeneca company on a potential corona vaccine. The researchers said that the vaccine produced antibody and killer cells which combat the infection, and those antibody lasted for at least 2 months. How about the condition of the vaccine in UAE? It was revealed that the partnership between Chinese pharmaceutical giant Sinopharm China and Abu Dhabi-based cloud computing firm have entered third phase testing for a vaccine with the hope that it could enter the market by the end of 2020 or early 21. I thank you all for attending and stay safe. Thank you.
Thank you, Dr. Amina, for a brilliant talk. Now it is the time for question and answer sessions. We have received about 9 questions. I'll be reading out one by one, and the panelists can answer. The first question is whether COVID-19 transmit via airborne, because according to WHO, airborne method is still not confirmed. Can Dr. Raza answer this? Rasha?
Yes. As I have mentioned, there was a scientific debate about the airborne transmission of COVID-19, and the WHO already submitted update about this, and it said that in poorly ventilated, crowded indoor places, we cannot rule out the airborne transmission. And before, in the past, WHO only mentioned aerosol is accepted at the healthcare setting only if there is a close contact with patient. So this was what the WHO mentioned in the last few days.
Okay, thank you, Dr. Rasha. So still it is not very clear. Earlier, WHO said it is only aerosol, then they told it is airborne, then still debate is going on. So whatever it is, we have to take extra precautions, whether it is airborne or aerosolized. Once we get the infections, it is the same. The next question, again to Dr. Rasha, what is the R value of SARS currently in UAE? How to predict the change in R value from the current? And one more question in that, how to predict when R value is going to be below 1?
R value, different country can estimate it through different mathematical models. These R value are used to tell us how many one individual will be infected from a single infected person. Here, at the level of UAE, the evidence showing that it earlier was from 2.2 up to 2.7, and later on this number increased up to 5.7 median. So this means that the infectiousness of the virus is increased. So the scientists do such mathematical study to study this over time, and this is the result for COVID-19. Regarding SARS, as you have seen in my presentation, a clear evidence that showing that COVID-19 is contagious than SARS by number, by the value of R value.
Okay, thank you, Dr. Rasa. The next question is, how reliable and confident are we as health professionals in curbing the spread with the advent of vaccine and the propensity of virus to mutate? Dr. Bhatt, can you answer? Hello?
Muted. I have to be unmuted.
Yeah, corrected now.
Yeah, okay. The answer is very simple. Vaccine is a substance which is introducing a virus that is not very active, but it is still alive. And then body reacts in the same way as it would have reacted to the infection. But it is a very small dose of the virus, so there will be not many consequences except producing antibodies to neutralize the infection. And it is remembered for a long time, memory cells are there, so hopefully the infection won't come. But word of caution, it takes a long time to perfect the vaccine. Making a vaccine is not a problem. Making sure there are no side effects is the problem. And earlier, the fastest made vaccine was a measles vaccine, a mumps vaccine. It took 4 years for that vaccine to come. So nobody can be sure if the attempt is made to make the vaccine in 6 months, 8 months. It has never been done before. It is very dangerous to do this sort of a gamble and try to push to the extreme to make a rapid vaccine, because this very close, the perfect and the not so perfect vaccines are very close. And the first level you test it on 20 subjects who are totally controlled. Second level you test on 1,000 subjects. And the next level, when you go out into community, you are using uncontrollable number of people. And if there is a small problem, it will reflect as major side effect. So having said that, vaccine will come, but whether a safe vaccine will come soon is the big question mark. Second, Dr. Rasha said it's spreading at various speeds, and when it is spreading, it is going out into the community spread, and when it goes into community spread, it involves people. How fast the susceptible population get involved? About 70% get involved, then the herd immunity comes, there is no need for a vaccine. So it's anybody's guess whether we will have a rapid vaccine, safe vaccine, or the need for a vaccine won't be there when the vaccine finally comes. We don't know. We have to wait and see. Thank you.
The next question is also to Dr. Bhatt. Why children are less susceptible to COVID and cytokine storm?
Yeah, this is very interesting. We observed this, that we initially thought that the children never get this disease because they are immune. But what we now see is they do get this disease, the infection, but they remain asymptomatic and they may not suffer. But they do suffer in a peculiar way because the immunity is different, and the way the immune system responds is different. There is this picture known as inflammatory syndrome, what is known as the inflammatory syndrome, which is produced by the COVID. It is something like Kawasaki disease, which is seen in pediatric population. It's a vasculitis. It is an autoimmune disease seen in the pediatric population. A similar multi-system inflammatory, pediatric multi-system inflammatory syndrome, PMIS, is seen in COVID infections, but to a much lesser extent. We don't know why. Maybe in the initial period, they have the mother's antibodies which protect, the mother is protecting even after birth, or it may be that they have active thymus, which may be giving protection. Only when thymus involutes, the T cells are then to be reminded of their job. So it probably after puberty, they require or they get susceptible to infection. This is one of the explanations given. Having said that, if a child is immunosuppressed for any reason, including malnutrition, this is the most important thing. The basis of immunity is not vaccine, is not drugs, it is nutrition. If someone has adequate nutrition, does social distancing, does care for others and himself, mask, social distancing, and hand wash, he will not get coronavirus as long as he remains mentally positive, eating well, and doing correct exercise. His chance of getting coronavirus are very, very low. So immunity does not only depend on vaccine. Without vaccine also we can prevent the disease.
Thank you. The next question is, regarding low steroid level during night and more death due to COVID during night. There is a question: does changing circadian rhythm or keeping awake long duration during night, will it protect from high mortality?
Yeah, this is the first part of the question. We have a definite answer. The steroid levels drop and the melatonin levels go up. Now, why the steroid levels drop? This is a circadian rhythm. This is a rhythm with which we are born with, and this is the rhythm that we are alive with. If we are alive, it is because we are responding to stress. And we were hunter-gatherers. We hunted for food and got our food. We found an animal, we chased it and killed it. Sometimes we got killed. Now, this stress reaction is what is keeping us going. And this is when we are awake. Our steroid levels are always there, protecting us when we are awake. When we sleep, all our defenses are down, including the steroids. While we sleep, melatonin levels go up. So if melatonin levels go up and steroid levels go down, we have lack of steroid at all times. But what happens in the presence of COVID infection? Steroid is needed. Body has to produce steroids. Body doesn't realize that it has to produce extra steroids because of the melatonin and sleep. So if the person is sleeping, the level of oxygen goes down, level of the steroid goes down, and they have found mortality correlation at that point of time. Now, the second part of the question, will that keeping him awake help? Difficult to answer this because it's much easier to give steroid than to keep the patient in ICU awake. Probably, if you give steroids and help the patient to if the what is deficit is corrected, it is useful. Second part of the answer is practically what happens is if we have a patient has adult respiratory distress syndrome, he will need a ventilator at the end. If nothing works, ventilator will be needed. When we use a ventilator, we do three changes from the normal. We give a low tidal volume, we paralyze the patient so that he doesn't compete with ventilator, and we put the patient in prone position. So these three things being done, it is impossible to sedate the patient, or it's impossible to expect cooperation if the patient is not given steroid. If we sedate him, the melatonin level goes up and the steroid level will be coming down, and it is very difficult. So we need to give steroids. That's a more intelligent option. That's a safer option than waiting for and keeping him awake and disturbing him. We can't keep him awake when he's on ventilator. We have to sedate him and paralyze him.
Okay, thank you. The next question again for you. This is regarding the use of steroids. Is it advisable to use methylprednisolone in COVID-19 who is non-diabetic? If no, what is the alternative treatment?
Well, this question I will answer in two parts. Use of steroids in early part, use of steroids in late part. Early part, asymptomatic or person who has no symptoms, just the virus, no need for steroid. When the immune system starts reacting and the immune response is in the form of little breathlessness, slight cough, but not hypoxia, not enough to warrant admission, it is believed that giving budesonide by nebulizer, this is very interesting. We give this in asthma and it works. They say that this works, and they even say that certain pockets in Texas are using this, and one of the doctors in Texas claims to have used it for 5 months with zero mortality. He also quotes certain countries like Japan and Korea who are using this method of early use of budesonide for all patients who have any respiratory symptom, irrespective of oxygen levels. The outcome is very good. Now, let us say that it has crossed the stage, he comes to hospital only later, then we use the dexamethasone. Now, this came out in the recovery trial. The trial which said dexamethasone is good is recovery trial. But our own people in India, particularly Tamil Nadu, here I'm quoting my old student, Dr. Ajay Mohan, they have used methylprednisolone with the same advantage. So the experience, they say that methylprednisolone is as good as dexamethasone, but only at the stage of hyperimmune response. That is after 10 to 12 days, that stage. It has no role in the first 5 days and probably a questionable role in the early stage when inhalation of budesonide is safer. But we must understand that there are two reasons for hypoxia. Not only the hyperimmune response, there is a lot of thrombosis coming in. So as the patient is wheeled into ICU, obviously you know he's a bad patient. He needs to be started on heparin. He needs to be given high flow oxygen. He needs to be given antibiotics because this is the second stage of bacterial infection. and here he needs to be given supportive measures. That one of them is steroids. So steroid is a role in the second part and the first part. First part is only no steroid, the ordinary immune response, inhaled steroid, and the hyperimmune response severe, apparent with the injectable steroid, either dexamethasone or budesonide, are supposed to have a similar advantageous effect.
Okay, thank you. The next question is, what about using antibiotic in case of secondary infection, prevention of secondary infection?
Yeah, the use of antibiotic, there is a role that is, now we are talking of three stages. One is the stage of infection. Predominantly virus is multiplying. There the role is for supportive treatment. You don't have any antiviral is fine. Supportive treatment is good enough. Nutrition, eating, thinking good things, living well, eating well, going about normal inside the house, wearing a mask, preventing others from getting. That's the first. Then comes the second stage of lung involvement. The lung involvement in the initial period, if it is happening, it is viral. After 7 days, if the lung is involved before 10 to 10 days, it is probably bacterial, where they have fever, where they have neutrophilia. I showed you a picture from Mangalore, where they had rapidly evolving pneumonia with neutrophilia sent by Dr. Alam Nawaz. This is bacterial pneumonia. This is maybe related to COVID, but it is not COVID. By the time the initial virus, that is the PCR, will become negative, only the pneumonia will be there. So we then go by the features of the radiological features of pneumonia, that is rapid spread, obliteration of the angle, bilateral spread. But if it is the CT scan is showing the feature of a halo sign, or if it is showing the features of infiltration, the peripheral involvement and involvement of round lesions, this is COVID. And there, the viruses may not be there, bacteria may not be there. It is a COVID producing immune response and the damage to the lung. So, in the presence of neutrophilia, high fever, 7 to 10 days, probably it is bacterial. There, the treatment is antibiotic. Some drugs do work wonders there. Ceftriaxone is a good drug. Some of the macrolides work very well. When you have the next stage, after 10 days, 12 days, that is the time they get the hyperimmune response and COVID-related pneumonia. And that is when neither antibiotics nor the antivirals will work. The supportive treatment, high flow oxygen is very good at that stage. That if high flow oxygen is working, you are preventing the ventilator. Now, what is observed in Tamil Nadu, and some of my friends here from Russell Kaima, Dr. Martin from Russell Kaima tells me, is that night their oxygen saturation drops suddenly after the 12th day. And that's disastrous. That's ominous. That is where we shift them from high flow oxygen to ventilation. So ventilator is not the first choice. It is the choice only and only if high flow oxygen doesn't flow. I must say that the team headed by the doctors in UAE, in Russell Kaima, and so there are many of them working there. One of them is my personal friend, Dr. Martin Thomas. He gives me inputs, and I must congratulate their team for excellent work. They have made our life safe in Russell Kaima. So have our students of the Rakcoms, whom I'm ever grateful. Thank you.
The next question is, if patient is not having any sign or symptoms, but he is positive, is it recommended to take vitamin C or no treatment is needed?
Okay, the positive for PCR, I think you are talking about PCR or antibody.
No. If patient is not having any signs and symptoms, but is positive, is it recommended to take vitamin C? Positive for infection.
Okay, now I'll answer this question in two parts again. If the patient is asymptomatic and he has got PCR positive, that means it's early infection. He needs to be isolated. He has to wear a mask so that others don't get it. Others contacts are to wear a mask because they shouldn't get it. So his wearing mask is extremely important. Not going out, isolating himself, quarantining himself, extremely important. There is no antiviral treatment there. And there is no need for any other drug because he is asymptomatic. Vitamin C might have a role, zinc might have a role, but it is not a therapeutic role. Coming to the second answer part, whether that was an antibody test that was positive. So how do we quickly recapitulate this? PCR negative, antibody IgM positive, and IgG positive. That means he has got the infection, and the virus has disappeared now after 7 days. If PCR is positive, it is definitely in the initial 7 days. This is active infection. PCR positive, IgM positive. IgM is the first antibody to come. PCR positive, IgM positive, early infection. PCR negative, or you are not done PCR. You have done only IgM and IgG. IgM has come positive. Early infection, do PCR. If it is positive, infective. So PCR is an evidence of early infection if it is positive in 7 days. Now, if the PCR is positive after 10 days, 14 days, it is because the dead RNA is there. The virus has died, RNA is released, this RNA is picked up. That is what Gary Mullis, the founder of the test, said. Always it doesn't say that it's infection. It also may mean presence of persistent RNA, RNA hanging out there. So it is useful only in the 7 days. Second thing is, if antibody IgG is positive, that means the disease is over and is probably come out of it. So PCR negative, IgM positive, IgG positive, PCR negative, recovered. So this is the importance of the test. This is how we
one last question. Is there a possibility that herd immunity can be developed by 2021? In that case, we don't need the vaccine that are being developed now. What are the doctor's thoughts on this?
This is what I told, that the longer it takes for vaccine to come, the lesser the utility of that vaccine will be for this epidemic. This can come again. This is not one-time thing. It can come again and we may need the vaccine. So vaccine is required, but whether it helps this epidemic, we cannot say. I would request Dr. Rasha to answer this question because she knows better than me because of the R factor. The question, Dr. Rasha, is whether the vaccine will help this epidemic.
Yes. First of all, let's know what is the meaning of herd immunity. Herd immunity means an individual exposed to infection and develop immunity as a result of vaccine, as a result of infection. As we have mentioned in COVID-19, R naught is high, increased. COVID-19 is highly infectious. And we have mentioned now a median estimated to be at 5.7. And we have mentioned R naught give us a prediction about the proportion of individuals are in need to be immunized by the vaccine or by herd immunity. So with 5.7 R naught, this means about 82% of the population are in need for either a vaccine or a past infection. So we cannot say herd immunity will take place alone unless there is a vaccine will be given, because the rapid transmission of COVID-19 among cases, this the need for a presence of a vaccine to be given. Thank you.
Okay, we have come to the end of the session. I thank all the panelists as well as president of university and the organizers, co-organizers, IT department, facility department, etc. for arranging this webinar. We have our next webinar on 3rd of August. Initially it was scheduled on 2nd, because 2nd is a holiday, it is scheduled on 3rd August. And there was one question about the false positive of the COVID test, because that next week we will be mainly discussing on diagnosis of COVID, various tests used, as well as treatment. That's why we will be answering that question in the next webinar. Thank you all.
Students, and very importantly, behind the scenes, a lot of people have worked here. IT work with these utility people have worked. A lot of people have worked behind the scenes. Let me tell a heartfelt thank you for everyone. Thank you very much, and thanks a lot for the audience also. They were keeping this very live session alive. Thank you.